Hello everyone, my name is Daniel Steele and I'm coming to you from the traditional, ancestral, and unceded territory of the Musqueam people. In this lecture, I'm going to talk to you about the ethics of safer supply. This lecture will cover the Duthie and colleagues reading from week 11 of the syllabus. So let's just begin with a little bit of background about treatment for OUD. As is probably quite familiar to you and came up in the first reading, pretty much everybody agrees that there needs to be more treatment, but people don't always agree about what treatment should mean. In the reader article, he suggested a conflict between people who focus on sort of abstinence-based treatment versus people who focus on treatments that involve prescribing opioids. But when it comes to prescribed safer supply, that's not the main difference, especially not in Canada or BC. The main difference here is between people who advocate more traditional approaches to treatment that prescribe opioids to less traditional approaches like prescribed safer supply. So let's look through examples to understand what that means. So let's start with opioid agonist treatment. Opioid agonist treatment prescribes opioids like methadone or buprenorphine to control withdrawal symptoms. And the idea is that the patient can take these medications, which are opioids, but which are, the thought is, less dangerous than unregulated opioids that one would find on the street. And that this can allow it will maintain the physical dependence on opioids, but many of the other aspects of the opioid use disorder can be treated, and the dangers of the use of the unregulated opioids can be reduced. And I should say that this kind of treatment is sort of very well established, and there are many randomized controlled trials and so on to suggest that it's effective. A different medication-based treatment is injectable opioid agonist treatment. And this provides injectable opioids like hydromorphine and diacetylmorphine, which is the pharmaceutical name for heroin, under supervised facilities. So people will go to a facility that has a pharmacy on site. They get prescribed a certain dosage, and they inject that dosage themselves under supervision, and they might do that, say, 2 or 3 times per day. And this exists in Vancouver. It also exists in a few European countries as well. Finally, prescribed safer supply, which is the main subject for this lecture, involves prescribing hydromorphone tablets, usually, and which in BC until February, for which take-home doses were allowed. There also have been some prescribing of fentanyl patches as well under supervision. But hydromorphone was the main sort of medication that was prescribed under safer supply. And so if we think of the controversy in BC, it's not so much between people who are, at least within the sort of, in the community of people who are experts on this subject, it's not between people who are abstinent-only advocates and prescribe safer supply. Rather, among people who are in the sort of opioid treatment world, it's between folks who are advocates of opioid agonist treatment with methadone and buprenorphine, and folks who are safer supply folks. And so that's like within the sort of the world of medical and addictions treatments, this is where the controversy is. It can also be helpful to think about the difference between treatment and harm reduction. So if we think of treatment, usually this is going to involve a diagnosis by a physician. So if we're talking about opioid use disorder, and usually if it's if the treatment involves prescribing opioid medications, then that dosage is going to be something that the physician signs off on and maybe consults with the patient, but the physician has to approve it. Harm reduction, on the other hand, is generally not going to require any kind of diagnosis, and the dosage is normally going to be up to the user. And in harm reduction, normally you're not providing the drugs themselves, but only things that reduce the risks of using those drugs. So that could be like a safe injection facility or naloxone or something like that. So in this picture, even though harm reduction and treatment isn't a sharp line or a sharp division, prescribed safer supply, it has these two features that put it more on the treatment side of things. Finally, if we think of prescribed safer supply versus legalization, these are again not the same thing. So prescribed safer supply is only available given diagnosis by a physician, and doses are chosen in consultation with the physician. Legalization would mean something like opioids are available for purchase in government-run stores. So if you think of government-run liquor stores, you could imagine a similar type of establishment for opioids, and then individuals could go in and buy the opioids and decide how much they wanted to consume themselves. So again, this is what Duthie and colleagues are talking about: prescribed safer supply, not legalization. Okay, so with that background, Duthie and colleagues provide two main arguments in defense of prescribed safer supply. The first is that prescribed safer supply improves the well-being of patients, so that patients who receive it, of course, and it does so in a number of ways. It obviously can protect patients from the harmful effects of unregulated drugs, which might contain things like fentanyl and so on, and also the fact that, they're receiving these drugs, say the hydromorphone tablets, means that they don't have to be, engaging in activities to gain money to pay for them, right? So, for instance, if someone who has to buy the unregulated drugs on the street, then they might have to engage in crime or sex work or other things to get money to pay for those drugs. If you're receiving them from a prescription, then you don't. That frees up your time and your life to be able to do other things. So maybe you could try to find work. Maybe you could try to address medical conditions that you have. Maybe you could, reconnect with family members and so on. And so there's research that suggests that prescribed safer supply can have beneficial effects on patients. And I'll mention one such study in a bit at the end of this lecture. In addition, Duthie and colleagues argue that prescribed safer supply improves patient autonomy by offering an additional treatment option. And that's important because the treatment modalities like opioid agonist treatment with methadone or buprenorphine, this doesn't work for everyone. Things like injectable opioid agonist treatment are very difficult to scale up, and also tend to be very restrictive because you have to go on site to and use it under supervision. And so prescribed safer supply is much less restrictive than some of these other alternatives. Okay, but that brings us to diversion, and diversion is really important because it's one of the major issues that's been, that comes up in public discussion surrounding prescribed safer supply. And I think it's probably one of the reasons that led to the change in policy last month by the BC government to no longer allow the take-home doses. Clearly that seems to be aimed at preventing diversion. And so diversion occurs when medications that are prescribed to a patient are used by others than whom they're prescribed. So this can happen in lots of different ways. If you leave a bottle of medicines that you were prescribed by your doctor in your medicine cabinet and your roommate or somebody takes them, that would be diversion, for instance. But diversion has been discussed quite a bit in relation to prescribed safer supply in the media. Here's a link to a story if you'd like to follow that. And there's sort of two main types of diversions that, in the case of prescribed safer supply, that we can think about that differ in terms of their ethical sort of dimensions. The first is that patients might sell the take-home doses. And this might be done for a number of reasons, but the effect of this, of selling the take-home doses, would be to increase the quantity of opioids available in unregulated markets. And there the concern is that could result in more people using opioids, more people developing opioid use disorder. And so that's sort of the ethical concern with that type of diversion. Another type of diversion is that patients may share their doses with others who suffer from opioid use disorder and essentially who can benefit from these prescribed, from this kind of program, but for whatever reason aren't signed up for this program. And so in that kind of case, the diversion is actually something beneficial because somebody might, take the shared, hydromorphone tablet and therefore, not use, say, unregulated opioids that might contain fentanyl or something else that might, be deadly. So in December of 2023, the Office of the Provincial Health Officer issued a report on prescribed safer supply that supported continuing the policy and, in fact, recommended expanding it. And for our interests here, there's some of the ethical principles that they articulated in this report that we can look at. So one of the most important of these stated that when harms to individuals are certain or severe, and then there's ethical justification to implement effective interventions that reduce or eliminate those harms, even when it means that there may be some uncertain risk to other individuals in the broader population. And so here the idea is that since the risks from fentanyl and the unregulated drug market are certain and severe, it's justifiable to implement prescribed safer supply, even if it has some uncertain risks about diversion. That's the idea of this principle in this context. And the second principle here is saying that when there are uncertain risks to other individuals or the broader population, simultaneous action must be taken to identify these risks and to reduce them as much as possible. Now, so one of the big questions about prescribed safer supply and diversion was, is prescribed, to what extent is diversion a problem? To what extent is this actually causing people to, be exposed to opioids who otherwise would not, and for, causing, sort of new cases of opioid use disorder that wouldn't have otherwise happened? Well, in the report that I just mentioned, it suggests that, in fact, this isn't going on because if you look at the incidence, the new cases of opioid use disorder in youth, you see that it's declining. You see for people over the age of 19, it's just sort of declining very slightly, but mainly sort of holding steady. But among youth, you can see there's a sort of downward trend with a little hiccup here from the COVID-19 pandemic, but generally an overall downward trend. And so this is taken to suggest that diversion of prescribed safer supply is not leading to increased opioid use disorder among youth. Right. So finally, let's look at two contrasting studies about prescribed safer supply. And these, in some ways, get at some of the big issues, I think the big concerns that are behind some of the recent policy changes about prescribed safer supply in BC. So if we start with this study here on the right that was published in the British Medical Journal, this was one that focused on patients who were prescribed safer supply, and it was comparing them to other opioid use disorder patients who were not receiving prescribed safer supply. And essentially this study found that the prescribed safer supply reduced mortality risks, so that people who were prescribed safer supply were less likely to die than the similar opioid use disorder patients who are not receiving prescribed safer supply. So obviously this supports the idea that prescribed safer supply can be beneficial to patients who receive it. And this isn't the only study that suggests benefits to patients who receive prescribed safer supply, but this is certainly an important one. On the other hand, this study here from the Journal of the American Medical Association was thinking about the population effects, because if you're concerned with diversion, you're concerned not only with the people who are being prescribed the safer supply, but you're concerned that some of that supply is being diverted, and that might cause other people to develop opioid use disorder who would not otherwise have had it. And so that means you want to look at the sort of overall population effect. And to do that, this study compared BC to two other Canadian provinces for which data was available, Manitoba and Saskatchewan, in the period of 2016 to 2022. And so essentially this study did not find that BC had sort of an advantage in terms of outcomes related to opioid use. So that opioid prescriptions and opioid-related hospitalization, but not deaths, increased in BC compared to Manitoba and Saskatchewan. So that they were kind of similar, but there are more hospitalizations in BC than these two other provinces. Now, the authors of the study emphasize that it's not easy to make an immediate inference from these data to say, for example, that prescribed safer supply has failed or something like that, because of course there can be many differences between Manitoba, Saskatchewan, and British Columbia that might explain why there wasn't, say, a reduction in hospitalizations related to opioids in BC compared to Manitoba and Saskatchewan, even though BC had the safer supply program and Manitoba and Saskatchewan did not. So maybe there's other differences between these two provinces that explain that. But it does at least suggest that there's no sort of clear and obvious population benefit from this policy in BC. So here there's a link to a CBC article that's discussing these two studies. So the key issue then here to bring this back to the ethics is, on the one hand, we've got benefits to people who are being prescribed the safer supply, and then this population concern. And obviously the population concern is not easy to assess because diversion is something that's not legal, and then therefore it's not going to be easy to measure. Okay, so these can be things we'll discuss further in class, and I'll see you again soon. Bye-bye.